All right. Good afternoon, everyone. My name is Maan Malahfji, and welcome back to Multimodality Imaging Conference. Today, we're going to talk about pericardial disease. I'll start with echocardiography for the first 30 minutes, and then Dr. Nabi is going to talk about cardiac CT and cardiac MRI. Here's an outline of what we'll review. We'll go over the pericardial anatomy, pericarditis, pericardial effusion and tamponade as it relates to echocardiography, constrictive pericarditis, the important condition of effusive-constrictive pericarditis, and then a few miscellaneous topics in pericardial disease. The pericardium is two layers that are primarily a visceral pericardium and a parietal pericardium. Within the visceral pericardium, there's an inner serosal membrane, and that's actually attached to the cardiac epicardium. If you look at these pathology samples, if you have epicardial fat, it's this layer that's right on top of the epicardial fat layer, or it could be the layer of cells that are directly adjacent to the cardiac myocytes. Within the parietal pericardium itself, there's actually two layers. The outer fibrous layer, and that's the big one that we see on CT and MRI. And then there's an inner serosal layer, and that's just a reflection of the visceral pericardium. If you imagine trying to punch a hole into a balloon, you create those two layers, and within them you create a space where pericardial effusions can develop. If you actually cut the parietal pericardium, you notice that it retracts, and that gives you an indication that it's actually exerting force and pressure on the myocardial chambers. So the pressure within the pericardial sac in of itself is usually directly related and very close to the right atrial pressure. And in a way, it's kind of containing the heart within its location and preventing it from overexpanding. Here's a patient example to get us started with pericarditis. A 35-year-old man with pleuritic chest pain, changes in body position. You do an EKG in the ER, you notice the diffused ST elevations with PR depressions, and you've made the diagnosis of pericarditis clinically, but where does echocardiography factor into this potential scenario? You notice that the ventricular function is overall normal, LV and RV size are normal. You notice some echogenicity surrounding the pericardium, but differentiating that being an inflammatory exudate versus pericardial fat is not an exact science, and you have to take into account the clinical picture, and that will come as being much more important in constriction cases. So echocardiography was often normal. This patient had an MRI which confirmed the pericarditis diagnosis. But when you do an echocardiogram on these patients, you have to look out for a pericardial effusion, reports the size, location, characteristics. If you have an exudative effusion, you may have some stranding and adhesions. Pay attention to wall motion changes to try to infer whether there is coexisting myocarditis. And then watch out for early constriction features, such as the presence of septal bounce, pericardial thickening, and increased echogenicity. In this older study, where TE was done on patients getting pericardiectomy, the evaluation of pericardial thickness on TE was actually fairly well correlated with CT evaluation. So take a look at the pericardium by echo as well. You can't always make definitive conclusions, but visual assessment is also very important in these patients. When we talk about the effusion size assessment, there's a bit of an arbitrary definition to it, and primarily it's using linear dimensions, recognizing their limitations when it comes to inferring the pericardial volume, which is in milliliters. So a trivial effusion is seen only in systole and is less than 10 millimeters in diastole. A small is seen in both systole and diastole, less than 10. A moderate is between 10 and 20 millimeters, and then a large effusion is greater than 20. Recognize as well that there's going to be varied dimensions in the same patient depending on the window that you obtain. And really, you're trying to infer a 3D structure by using 2D dimensions. So the limitations of this should really be factored in when you report a patient's scenario. And it's really fair game to try to report, for example, the largest dimension and where it is, taking into account the general picture, for example, a localized versus a circumferential effusion. When you go by volumes, generally less than 100 mLs is small, 100 to 500 is moderate, and then greater than 500 milliliters is large. Recognize another caveat, which is body position when the patient is being imaged. So, for example, a CT scan done with the patient laying flat on their back versus an echo done with the patient laying on their left side. Another potential limitation to think about is the heart size. So an effusion that's 10 millimeters in diameter in a heart that's 7 centimeters is going to be a different amount of mLs compared to the same exact diameter, 10 millimeters of pericardial effusion, but the heart size is much smaller. And then, we often get questions and consults about, the CT reporting a large or a moderate pericardial effusion, where you look at echo and it looks very small or not really that impressive as it does on CT. The pericardial volume itself is still the same, but on CT you're getting a much wider field of view. There's these scenarios where if the CT was not gated and done during systole, the heart will be contracted, and then the effusion may appear to be larger than it does when we do the echocardiogram. The physiologic significance of the effusion is still primarily assessed by echo and your clinical assessment. Don't forget about normal structures. So there's pericardial sinuses and pericardial recesses, and really the fluid goes up in between the great vessels. You have the transverse sinus and you have the oblique sinus, which are normal structures, and fluid will often be present in those areas. When it comes to tamponade, you have to keep in mind that it's a continuum. So there's going to be remodeling of the pericardium in someone who develops a pericardial effusion over a longer period of time, where the relationship between volume and pressure or compliance of the pericardium is actually shifted to the right, and changes in pericardial volume may not lead to the same change in pericardial pressure compared to someone who develops pericardial effusion rapidly. Let's review some of the core concepts in pericardial disease in general, and that is ventricular interdependence, and then the changes in pericardial pressure and intrathoracic pressure. Like I mentioned earlier, your pericardial pressure is usually very closely tracked to the right atrial pressure. And then as you inspire and expire, you're creating changes in your thoracic cavity. So in this person that's normal, you usually start with an intrathoracic pressure that's closer to the right atrial pressure of 0 or so, 0 to 3. Similarly for the intrapericardial pressure, slightly higher. And then as you inspire, you create a negative pressure within the thoracic cavity. And that tracks and it is transmitted to the cardiac structures, and that includes the pericardium as well as the ventricle and the atrium. And as a result, with all the pressures dropping to the same extent, the gradient that allows filling from the pulmonary veins to the atrium is largely unchanged. Now contrast this to a patient with a large pericardial effusion that does not allow the transmission of those changes of thoracic pressure to the heart. And notice here a key important piece is that the pulmonary veins are isolated from this thoracic cavity change. You notice that as the patient inspires and creates a negative pressure, first of all, the intrapericardial pressure is higher, and then that gradient is actually abolished during inspiration, which will lead to a lower flow rate from the pulmonary veins to the left atrium. And that's going to manifest on echocardiography as changes in your Doppler parameters of the pulmonary veins, the mitral valve, and conversely on the right side of the heart with the hepatic veins and the tricuspid valve. So that's one key important aspect to keep in mind, which is that the pressures in the thoracic cavity and the intracardiac pressures have now become separate from each other in their interactions. And then this is what we see in the mitral valve inflows and the tricuspid valve inflows. A similar relationship the same phenomena occurs in constriction, but with minor changes. But what I want you to review here is what happens to the mitral valve and the tricuspid valve Doppler. So upon inspiration, like we said, there is loss of that normal gradient that occurs, and you'll have lower mitral valve velocities during inspiration with higher velocities on the tricuspid valve. You'll have systolic dominant flow in the pulmonary vein with a normal diastolic to systolic relationship in the hepatic vein, a small reversal in the atrial wave. Upon expiration, the opposite occurs, so the septum shifts back, and you'll kind of see this visually on echo as well. And now you'll have this diastolic dominant flow in the pulmonary vein, higher mitral valve velocities, and then the reversal will happen here on expiration. And we'll review this a little bit later on. So here's an example of pericardial tamponade. Notice the large pericardial effusion. Oops. And notice the indentation of the right ventricular free wall that occurs primarily in diastole. Notice the right atrial inversion that's happening during systole, where the right atrial pressure is lower. And then you see this on M mode, and that's a key thing to use for these scenarios because of the very high temporal resolution. You'll notice the swinging heart motion, and this case is fairly clear cut. But let's look at the Doppler findings. So one thing to notice here when you do your mitral inflow is the E to A ratio. Notice how you have lower E waves and taller A waves. And there's minor variation, but no significant variation across the velocities. When you look at the pulmonary veins, notice that there's a significant amount of variation here. And that gets into that previous slide where we show that the pulmonary vein Doppler or flows may not necessarily be still concordant with what happens on the mitral valve. An important aspect to notice here is the E to A ratio is low, not necessarily because the patient has diastolic dysfunction, but because in tamponade, most of the ventricular systoling now becomes atrial, where the pressure is, or the flow is allowed to be received by the heart. And then when it comes to interpreting those changes with the respirometer, these are always challenging, and the key thing that I want you to keep in mind is you go by the first beat after inspiration or first beat after expiration to decide which one to measure and if there's an elevation versus reduction. So here, and generally, and that's not 100% rule, inspiration is marked by an increase in the respirometer and expiration is marked by a decrease in the respirometer. And then what we'll do is beginning of inspiration, so first beat of inspiration, notice the lower wave velocities or Doppler velocities. First beat of expiration is higher velocities. Here's another example, and this is now getting into the caveats of discussing tamponade and discussing pericardial effusion versus pleural effusions. So this is one when someone with liver failure in the ICU being listed for transplant. He's hypotensive, he gets an echocardiogram, notice the RV compression, notice the fluid that tracks anteriorly and apically. We don't see it very much here on the left side, and we don't see much here. There is features of tamponade by virtue of the RV compression, and obviously the patient is clinically sick. Notice the lower E to A ratio, like we showed earlier, and then the lower velocities. So another key aspect to keep in mind is because of the reduction of intracardiac filling, the velocities on Doppler are also lower than normal, and you contrast that with constriction cases. Not huge variation, but low velocities, which is very important. So this patient gets further investigation to try to evaluate, is this truly a pericardial effusion or is there more to this story? So when you look at his x-ray, he has a large left pleural effusion, and they drained this, and now there's no more effusion. So one thing to keep in mind is a large pleural effusion may actually give you features of tamponade, and you have to keep that in mind. Here's another example that's also discussion of exception type cases. So someone with pulmonary arterial hypertension, RV failure, huge RV, non-compliant, RV hypertrophy, severe right atrial dilation, and he develops an effusion, as is the case for many end-stage PAH patients. Notice in this case that it's actually the LV and the LA that start suffering. And because of the RA and the RV pressures being elevated, even if the pericardial pressure goes way high, it may not be enough to cause inversion or compression of these, but rather those two chambers. And here you see on M mode, the left ventricular free wall actually getting inverted during diastole, as well as the respiratory variation on the mitral inflow. Here's another example. So someone who had cardiac surgery, and here you have to watch out for pericardial hematomas and localized pericardial effusions. So you see this effusion that does not appear to be a simple effusion with echogenic material within it. And you notice this area of echogenicity against the RVOT. And a key parameter here is to just look at the pre-op echo and see if this structure was there or not, to try to differentiate, is this purely pericardial fat or is there more to the story? And you notice the paradoxical septal motion post-surgery and then the LA compression. Here's another example of someone who's post-op from an LVAD, who now has RV failure with septal interaction of the RV and the LV, as well as pericardial effusion that also does not appear to be simple. And in this case, you know, the draining of the effusion may be necessary just based on your clinical impression of the patient. And obviously, those effusions will be less likely to resolve compared to a simple pericarditis type effusion. So you may not necessarily see chamber collapse, although here you see the LV is underfilled due to a multifactorial type of scenario where you have RV failure, tamponade/hematoma, and significant or maybe excessive unloading by the LVAD. So pulsus paradoxus, which we went over briefly, the paradoxus term to keep in mind. The paradox is that you, back in the old days with huge effusions, the paradox is that you're able to hear the heart, but in such severe scenarios, you may have a loss of pulse on inspiration. And you see this M mode of the aortic valve where there's no opening of the aortic valve just from very low pressures during inspiration. But you have to keep in mind that there's other causes. So someone with a COPD or asthma exacerbation with severe dyspnea, wide changes in the thoracic pressure, someone with a large left pleural effusion and PE like we reviewed. And then you have to keep in mind confounders in pulsus paradoxus / tricuspid and mitral inflow. Someone with significant AR, pre-existing diastolic dysfunction, someone with ASD, all of these potential scenarios will modify the likelihood of manifesting both tamponade type changes and constriction type changes. And then the chamber collapse is a nuanced conversation. So, in practice, you will not necessarily see cases where all the features of tamponade are present, or none of them are present. You're going to have cases where there's variation, where some features are present but some are not. And remember that the imaging findings should really guide the management, but the management should really be decided based on the clinician's assessment and the patient's presentation. So the findings on echo may be present at an earlier stage compared to the clinical manifestation of tamponade. The other aspect to remember is because of the high sympathetic tone, some of these people will still have normal blood pressure, but may still be in tamponade. So you have to kind of trust or watch them carefully because they may not necessarily manifest it immediately. Let's talk about constriction. So here's a case, an 80-year-old man admitted with heart failure symptoms, history of esophageal cancer, prior surgery and chemotherapy. And you notice the paradoxical septal motion with the septum being pushed from the RV to the LV. Notice that it doesn't occur with every beat, but rather intermittently. And that's the key term of respiraphasic changes in the septal motion. You notice the same change here, and then you notice the pericardium. Here's where kind of looking at the pericardium visually is important. Notice how the ventricle is kind of tethered to this pericardial layer here. It's not sliding back and forth. And then when you look at the Doppler across the LVOT, you notice this beat that does not lead to any significant outflow from the LV. Here's another critical M mode that you have to keep in mind for the boards also. Notice the septal motion is paradoxical with shifting during respiration rather than with every beat. Here's a Doppler, and notice the key difference. You have a tall E wave and a high E to A ratio. So the patient will have a heart failure syndrome, will have findings of elevated filling pressures on exam and other imaging and findings, and then you'll have an abnormal E to A ratio. But the medial E wave or E prime will be normal or supranormal, with a reduction in the lateral E prime. And that's the opposite change of what you would see in normal patients. Notice the variation in hepatic vein Doppler, and this is a key, very specific feature of pericardial constriction, where upon expiration you have diastolic flow reversals in the hepatic vein, and we'll get into that some more shortly. Here's another example. So notice this echogenic area and the lateral wall, a tubular-shaped heart, atrial enlargement, the paradoxical septal motion. The difference is that this patient is an AFib, so we may not be able to as well rely on the changes across the mitral inflow. You see the IVC dilation, and then here you can still make the diagnosis by using the E prime velocities, where notice the E prime here is almost 16 compared to the lateral E prime. Putting all of these together, the Mayo Clinic has come up with criteria to try to improve the accuracy of echo diagnosis of constriction, and these is a series of people who were confirmed to have constriction on surgery. Key parameters to look for are the respiraphasic ventricular septal shift, which has high sensitivity, lesser specificity in of itself, and then the tall E prime or the supranormal E prime on the medial side. I wouldn't personally get hung up on the exact numbers, but rather the overall trend. And then the hepatic vein ratio and expiration of the reversals relative to the diastolic flow wave. Same thing, just notice the presence of expirations of flow reversal upon expiration. And if you add those up, if you have all 1, 3, and 5, so supranormal E velocities, septal shift, diastolic flow reversal, and hepatic veins, you end up with very high positive predictive value for constriction. And the reality is none of them is perfect in of itself, and you still have to kind of put everything together. Here's another example that kind of shows this potential limitation. So, a 76-year-old man, he had a subdural hematoma after he had passed out and fell. He had a prior or a recent pacemaker implant, and you notice this echogenic space in the anterior pericardium. You notice a slight and subtle septal shift here on the parasternal lung. When you look at the E prime waves, on the lateral side, it's about 8 or 9, and then on the medial side, 6 or so. So nothing very impressive, but you see the septal shift that is overall largely unexplained. And then the IVC is not very impressive. He gets a cardiac CT. I can't remember why exactly, but the key reason or the key finding here is that he actually has an ASD, and that could actually manifest or adjust your filling pressure interactions, similar to pulsus paradoxus, where you may not necessarily have all the features. And notice he has the pericardial hematoma, essentially, anterior to the RV with a minor calcification as well. On a follow-up, he still has the septal shift, no major variation across the mitral valve. He has the dilated IVC. And this patient didn't manifest constriction clinically, and this is one of those scenarios that are often termed transient constriction. So the vast majority of these they'll resolve on their own, But the key thing is to watch them with echo as well as clinically to make sure they don't develop the syndrome of full-blown constriction. Differentiation for constriction and restriction is a common question on the boards, less so clinically, but the key finding is, or the key starting point is presence of a heart failure syndrome. You can't really diagnose it in someone who doesn't have symptoms. The high E to A ratio, like I mentioned, dilated IVC is highly sensitive, and unless someone had just gotten a whole lot of diuresis, it's almost necessitated to get into the algorithm of trying to define if they have constriction or not. Then you look at the septal motion, and then you look at the medial E prime. If you have an intermediate one, you may have a mixed constrictive restrictive state. And then if you have a preserved or supranormal medial E prime with these changes, then you're fairly confident with the diagnosis of a constriction. With a minor exception being those cases that I alluded to earlier with severe asthma exacerbation, severe COPD exacerbation. And for those, you have to look at the SVC Doppler parameter, which I don't want to get into now in the interest of time. If you have an abnormal E prime, you've defined the patient as likely having an underlying myocardial disease as opposed to a pure constriction. Here's another example to highlight the effusive-constrictive pericarditis phenotype. So someone with end-stage renal disease, prior kidney transplant, now has failure of the transplanted kidney and has a large pericardial effusion. He gets the effusion drained, and notice that he has diastolic flow reversals, he has persistent elevation, dilation of the IVC, and essentially he has remaining features of a constriction despite draining the effusion. Later he gets readmitted with another bout of heart failure. This time he gets a pericardial window and a biopsy, and they report having inflammation symptomology on the surface of the heart. Notice the recurrent pericardial effusion now is no longer as transudative appearing as the prior one. Third admission for heart failure, notice tall E to A ratio, tall E waves, and then reversal or variation with respiration. Notice in this case, his annular velocities will be abnormal because he has underlying hypertensive heart disease, and he's been on dialysis or with CKD for many, many years. So you can't necessarily use them, but if you go by the ratio, the E prime is significantly taller than the lateral E prime. And you notice the expiratory flow reversals on the hepatic veins. So this is one of the examples of constriction, of effusive constrictive pericarditis. It's uncommon, but probably underdiagnosed, and has features of essentially tamponade / large effusion with features of constrictive pericarditis. And the classic description is someone who comes in with tamponade, gets drained, and he has features of constriction on cath as well as echo. There's rarely pericardial calcification. It's believed to be primarily the contribution of the visceral pericardium. And then the other two scenarios, other than the first one with tamponade, is someone with chronic or subacute constriction with an associated effusion, or someone with a chronic pericardial effusion. Think of the dialysis patients who have signs and symptoms of right heart failure, and those are challenging cases. Here's a case of transient effusive constrictive pericarditis. So this is a 25-year-old man, pericarditis presentation. Notice the abnormal septal motion. Notice the pericardial space has echogenic material in it, particularly here posteriorly. And then you notice the variation in the mitral inflow. And then his E waves his E prime waves will be high. He's only 25. But notice the medial E prime here is almost 16, whereas the lateral is about 8. And this patient was treated medically and it resolved. So the vast majority of them will resolve without having to need pericardiectomy. In a series from Mayo from a few years ago, 205 patients getting pericardiosynthesis, they found features of constriction in 16% of them. Their clinical phenotype was that they would have high percentage of neutrophils, loculated effusions, fibrinous material, and then on follow-up, only 2 of them needed pericardiectomy. So if you catch them early and you treat them with anti-inflammatory therapies, they'll often resolve. An old case series also from Mayo to keep in mind, which I personally haven't seen clinically, is presence of constriction in someone with surgically proved constriction despite having a histologically normal pericardial thickness. And this is just one thing to keep in mind, to recognize that no rule will fit every single patient. A couple, go ahead.
Regard to that was less than 2 millimeters histologically.
Uh-huh.
Right? Did they go back and say, okay, what did it look like on imaging in those cases?
No, not in this one, because it's an older series, 93 to 99, and from what I remember,
Translates to then 2 millimeters
on CT and MRI, yeah.
to say
Yeah.
that you can have, right? So I know people kind of tout this to say, oh, you can have
Yeah.
normal pericardial thickness and still have constriction.
Yes.
Again, I don't know if that necessarily means you could have 2 millimeters or less on imaging and still have constriction.
Yeah, and I mean, there hasn't really been any similar papers since on the topic other than the 26 patients. I suspect maybe it was sort of an inflammatory visceral pericarditis without, major parietal involvement, or there may have been more to the story, but I certainly haven't seen it. Yeah, I agree. Okay, so pericardial cysts, most often incidental, vast majority are case reports, really. Cyst infection, hemorrhage, and rupture can occur in someone who you are truly convinced they're symptomatic. You may consider referring them to surgery, and then make sure you verify that it's truly a cyst by CT or MRI. Tumors, when it comes to primary pericardial tumors, a mesothelioma is the most common one, but that's very rare. The vast majority will be metastatic disease, usually from breast, lung, melanoma, lymphoma. And for these, really, you should consider doing an MRI in almost all patients. Last case, so a young patient, atypical symptoms. Technically difficult study is usually added at the end of the report. And usually these are sort of a spot diagnosis type diagnosis to make. And this was essentially congenital absence of the pericardium, where it causes this shift of the position of the heart to the left side. It creates challenges with imaging. Most often it'll be young males that present and get an echocardiogram for either an indication or a non-specific symptoms. But the key thing to remember is that they may have coexisting congenital abnormalities, and those are the items that you have to look out for. The other one that's kind of similar is spectrus excavatum, which may also create a similar appearance to the parasternal long axis, and you have to look out for this. Okay, so shameless plug, pericardial disease clinic. If you guys have any of these cases, relapsing pericarditis, suspected constriction, we have now a clinic that's seeing these patients, and in collaboration with surgery and the heart failure guys. So text me, and I'll stop and hand it over to Dr. Nabi.
Okay, so I have, the task to show you how we can use CT and CMR for pericardial disease, and hopefully convince you that it is, much needed tool. So just a little bit about what was already discussed. Pericardial disease is very common. There are a spectrum of disorders, everything from infectious to inflammatory, where you go from acute pericarditis to this chronic thickened and scarred state, which would be your chronic constrictive pericarditis. You can have effusions, pericardial masses, and of course congenital processes. I'll be discussing mostly the acute and the chronic pericarditis, and the reason is solely because of time. Otherwise, I could have a lot to say about this. Now, all of these diseases, they have, are important cause of morbidity and mortality. They have a variety of symptomatology that they usually present with, about chest pain, shortness of breath, right heart failure symptoms being very common. And really it requires expert imaging and a really, a diagnosis will require really an integration of all the information that you have. Clinical, imaging, physical exam, and hemodynamics. Now, as was discussed, echo really is the first line test. We know why. It's readily available, a lot of strengths to it. But, when it comes to the pericardium, its biggest limitation is that you just don't see it. So not only do you not see the actual disease process, but you really have no ability to perform any tissue characterization as well of the pericardium, which you'll see becomes very important in a lot of these different disease states. And add on top of that difficult windows and patients who are morbidly obese or who have COPD, it just becomes even more challenging. So, that's where my role comes in then, is to educate you all how some of these advanced imaging techniques, including cardiac MRI, cardiac CT, and believe it or not, I have a couple of slides of PET, I try to do that now, can be very helpful and complementary to echocardiography. And all of them, other than PET, here, have these large field of views, they have very high spatial temporal resolutions, and have a great ability to actually see the structure that we're talking about today, which is the pericardium. Of these three, the real strengths in this space is really with cardiac MRI. And the reason is because with cardiac MRI, you can assess all aspects of this disease process. You can look at and evaluate pericardial anatomy and morphology. You can evaluate hemodynamics. You can look at tissue characterization, specifically the ability to identify inflammation, which will be very important in all of these disease states. And then, based on that, you can actually stage the disease, and this can help you guide your therapy and monitor your therapy. So CMR becomes actually a very, very critical instrument. CT is good. It has, as you know, very good spatial resolution. So you'll definitely see the pericardium, but its problem is, and so you'll see anatomy, you'll definitely see calcification. It's the best test for calcium. It's great for surgical planning, but its problem is, you really can't appreciate hemodynamics. And then we'll talk a little bit about, briefly about cardiac PET, which, there are some case series, and we've actually seen some in our own lab, where you can actually pick up pericardial inflammation on some of our FDG studies. So just a little bit before I get going in all of this, just a little bit of understanding of, with MRI, there's a lot of different pulse sequences. Each of these pulse sequences are applied to learn something different about the heart. So for example, a classic protocol that we use includes things like bright blood, single shot SSFP, and dark blood haste of the chest. This is really to show you your thoracic anatomy. We'll then do SSFP imaging of the myocardium itself. This becomes very important for calculating all our LV and RV volumes and function that you all are really comfortable with now. We will then do some black blood imaging that are T1 weighted and T2 weighted. The T1 weighted images are really the best sequences to allow us to evaluate pericardial morphology, specifically to see how thick the pericardium is and where it is thick. T2 weighted images help you identify water, and water translates to edema. So an edema is, an evidence for pericardial inflammation. Some supplementary sequences that you can use if you wanted would be some what we call these tagged cine images, and I will show you that, just showing you how the pericardium and epicardium interact with each other. We frequently do real-time cine SSFP imaging because this is how we assess the hemodynamics. We're able to see the LV and RV respiratory variation using this sequence, so it shows you the ventricular interdependence. And then, of course, the LG images, which all of you are very comfortable with using when trying to identify myocardial infarction or different types of cardiomyopathies. But here we actually are using it to see LG uptake within the pericardium to help us diagnose pericardial inflammation. So a variety of sequences really showing us anatomy, inflammation, hemodynamics, which will all help us stage and treat the disease better. So we discussed a little bit about acute pericarditis. As you know, the ESC have criteria which that in order to make the diagnosis, you have to have 2 of the following 4 criteria. The 4 criteria are typical pericarditis chest pain. Maybe you'll hear a pericardial rub. You'll look for widespread ST elevation or PR depressions, on just similar to what we had seen previously on an EKG, and look for pericardial effusion. And then they have some additional supporting findings that you can use, which include elevated markers of inflammation, such as C-reactive protein and ESR. And if you have the ability to do MRI, look for pericardial inflammation. So the trick with all of this is that, you know, MRI can be very okay, so as I've tried to figure out why the computer has frozen, but the trick with all of this is, you know, despite your patient presenting with acute pericarditis, the chances of finding a lot of these findings sometimes can be pretty low. So on the left side of the screen, you'll notice that thank you. What do I press? Okay. You'll notice that for patients having those typical chest pain symptoms, most patients will present with that. Pericardial rub, you know, if you're in the emergency room in a very loud environment, you may not hear it. Plus, you know, only 1/3 of the patients will have it. What about EKG changes? Believe it or not, only about less than 60% will have this. So, again, it's not as common as we like to believe. And then pericardial effusion, you know, also in acute pericarditis, less than 60% will have that. So, the problem is that, you know, a lot of these findings may not be present, and we're not really identifying the source of the problem, which is, again, the pericardium. These are all supportive signs inferring that the disease is there, but we never really looked at the pericardium. And this is where MRI can be very helpful. MRI can help you identify the pericardial effusion, and an MRI can definitely show you the pericardium and show you that it's inflamed. So let me give you an example. Here's a case, 48-year-old has positional chest pain of recent onset. Physical exam, as usual, is normal. EKG really just showed early repolarization. Troponins were negative. And in this patient, you know, he underwent an ischemic workup, which frequently is done, and it was negative. And then here are the echo images. And you know, I think we'll all agree, image quality is very good, function looks great, both of the left and right ventricles, the sizes look good. And you may notice that there seems a little bit of an echolucent space in the posterior lateral wall. Now, 2 points I want to make. One, you know, and I think this was mentioned earlier by Dr. Malahfji, you know, it can be difficult. Is this fluid? Is this just epicardial fat? This can all be very, very challenging. But even if it was fluid, you know, I think the point that I want you to take away from this is that we are inferring a disease process to the pericardium based simply on a secondary finding of pericardial effusion. We actually haven't seen that the pericardium is inflamed or thickened or anything like that. So, you know, a lot of echo findings are indirect assessments. So what about cardiac MRI? So here, you know, was this patient's cardiac MRI, and I think I'll play these images, okay. And what you'll notice is I've shown you 2 different sequences. I've shown you the SSFP sequence, which kind of, again, tells us about how the heart functions and things like that. And as expected, the heart functions completely normal. But if you look above the RV, you'll see there's a very thickened, this is the pericardium, and it appears very thickened. And you'll also notice that here inferiorly, posteriorly, where we saw it on echo, and also near the posterior lateral wall. And I concur with you, even with CMR, just by the SSFP images, I'm not sure. Is the pericardium thick? Is there some effusion there? Is it a little bit of both? It can be difficult. However, this is where the ability of tissue characterization becomes very important with CMR. We have some sequences, specifically the phase-sensitive inversion recovery LGE sequences, where, the only thing that can be black in those images are pericardial effusion. So, and as you can see, those are those sequences over here. So we can indirectly also look for evidence of pericardial effusion with these sequences, similar to what echo can. But the main point I want you to realize is that, this particular sequence, this PSIR, can be very, very sensitive to detecting very, very small amounts of fusion that can be very easily missed by echocardiography. We have the ability then, of course, of tissue characterization. If we do our T1 and T2 images that we had spoken about, T1 tells us the morphology of the pericardium. You can see here anteriorly the pericardium is quite thick. In general, this tends to be a structure that's less than 1 to 2 millimeters. It's curvilinear. This is, you'll have to take my word for it, is abnormal. And then with T2 imaging, which is really water imaging or edema imaging, this is a reflection of underlying inflammation. And so this brightness that you're seeing in the very same place as the thickness that you're seeing on your T1 images tells you that the pericardium is inflamed, and it's thick because of that. But of course, to make the diagnosis, you want to see the pericardium. And so we were able to see that the pericardium was thick. We were able to see that there's some water in it. But with these LGE sequences, a normal pericardium is really an avascular structure. There's not, too much blood supply to the pericardium. In the setting of inflammation, where there's not a lot of neorevascularization, a lot of granulation and fibrotic tissue, the pericardium all of a sudden takes up the ability to take up our gadolinium agents. And if you look at this heart, and I hope you'll get accustomed to seeing these images, all this brightness that you see circumambulating the heart is evidence of LGE uptake by the pericardium, very nicely showed by this kind of 3D sequence for LGE. So here we've actually directly assessed the pericardium and directly seen that it's inflamed, so you can be extremely confident of your diagnosis. Well, and this was this same patient who was then treated with anti-inflammatories. We have a lot of different anti-inflammatories on the market now, and you can see there's complete resolution of the thickness of the pericardium, and there's no further evidence of any inflammation. Now, what's important in this is what I'd like to point out is that we see a lot of young people who often have non-cardiac chest pain. And a lot of these patients go on and have ischemic testing, which is negative. And yet the actual identification of these patients' reason for chest pain is often unidentified. So this was a nice abstract that was recently published a few years ago, in which they showed that patients who had chest pain and a normal myocardial perfusion MPI, if you did MRI on them, about 10% of patients are going to have pericarditis that was not diagnosed. So, consider MRI, definitely, if you have patients who are coming back to you with recurrent chest pains. You've done all sorts of workup, they're negative. The story may or may not be very classic, but MRI could definitely pick up a cause of their discomfort and help get them the correct treatment that they need. The second abstract on the right just showed you that if you looked at the prevalence of finding pericarditis in patients. Obviously, those who are younger, generally between the ages of 40 to 60, this is when most pericarditis occurs, and the chances of finding a positive CMR become even higher, and in this particular case, up to 25%. Now, the other reason is that slide I show you with the 2 out of 4 criteria that you need, that is acute pericarditis. The problem is, as we all know, that once you have an episode of acute pericarditis, 1/3 are going to have recurrent pericarditis. And those 1/3 who have recurrent pericarditis, 50% will have multiple episodes of pericarditis. So, one, there's a lot of morbidity for the patient, with the continuing symptoms. But what's interesting is recurrent pericarditis unfortunately presents very differently from acute pericarditis. If you look at this abstracts, what they find is that a lot of these patients, and in fact in this particular study, almost 50% of patients, 1 out of 2 who has recurrent pericarditis, did not meet criteria of those 2 out of 4 findings that was recommended by the ESC document. So they're not going to present with chest pains. They're not. I mean, they'll present with chest pains, but they won't present with your fusions. They won't present with your rubs. They won't present with, all the other things you're going to be looking for. So the only way you're going to be able to diagnose these people is by looking at the pericardium and looking for inflammation. So it becomes even more important in recurrent pericarditis cases. And so this was just a consensus document that was published on who they recommend should get, cardiac MRI. And I'll just read a few, persistent chest pain after negative ischemic eval. Those patients who you suspect pericarditis, but you're not seeing any echo findings of that, or you're having a non-diagnostic study, consider this disease at this test. The other aspect of MRI that can be very helpful is you can actually guide and you can stage the disease and guide your therapy. And the way we do this is with a combination of your T2 imaging and your LGE imaging. And what studies have very nicely shown is, depending on where you are in this table, you can actually, kind of stage what disease and the patient is at, and it helps you identify how much treatment these patients need. So for example, in acute pericarditis, we already talked about, you're going to have a positive T2 and you'll have a positive delayed hyperenhancement. These people need active treatment. We have a subacute stage where when oftentimes patients have taken anti-inflammatories, they come to you, they may not have a pericardial effusion. Markers of CRP and ESR may have normalized because of treatment. You get a CMR, now T2 has gone, but the LGE is still positive. So this tells you, this is more now of a subacute state. These patients still have pericarditis, but it will help guide how long further you should continue treatment with anti-inflammatories and when you should consider discontinuing therapy. And then, as the disease process continues and and you go from this inflamed state to more of a fibrotic state, then now your LGE as well as your T2 will no longer be positive. So it can be very helpful, CMR, in staging disease and helping, therefore, guide therapy. I'm sorry. Okay. So a lot of these patients who present with pericarditis, mass majority of the times we feel it's some viral cause. Well, guess what? The virus is not specific just for the pericardium, right? A lot of times these patients will have concomitant involvement of the myocardium. And what better test than CMR to help you look for any concomitant damage to the myocardium? So here's a particular case where you can see LGE uptake in the muscle as well as the pericardium. And this would be a diagnosis of myopericarditis. Why is that important? Because if a patient has, one, it's very relevant for prognosis. These patients are obviously a little bit higher risk and may predispose you to also considering admitting these patients rather than early discharge. We've also, and this is just another similar case where this time, the actual process started in the myocardium, where you had a myocardial infarction and then spread to the pericardium, and this is known as perimyocarditis. So it all depends where the inflammation first starts. So when it comes to considering acute pericarditis, I know it's when do you consider treatment? Long slide, but I think whenever you have a complicated course, you should definitely be getting it. Or when you have non-diagnostic studies, you should be getting a cardiac MRI. All right, so we'll move on to the next phase of this talk, which is really the thickened and scarred constrictive pericarditis, and we'll see how CMR can add value here. So this is a very similar case that, as Maan had mentioned and had shown, which had all the exact findings that he had discussed. You have the diastolic septal bounce, you've got restrictive filling, and you've got respiratory flow changes across the tricuspid mitral valves. You've got the annulus reversus with the very high septal E prime. You've got an IVC that's plethoric, and you've got flow reversal in the hepatic veins and diastole with expiration. So, all of this, I think we all agree that this is constrictive pericarditis. And we went over, I'm not going to spend too much time here, but Maan went over very nicely what those classic findings are. But I have a question for you. If you had this case, based on just what you know by echo, what would you do with this patient next? Are you going to do an invasive left-right heart cath to confirm the diagnosis? Are you going to send the patient off to surgery to get a pericardiectomy? Are we going to consider a trial of anti-inflammatories? Do you just want to treat with diuretics, or do you want to consider further imaging? So you probably know where I'm going with this. I'm going to suggest to you consider further imaging. And the reason for this is because that not all cases of constrictive pericarditis need to go to the operating room. A lot of these cases will be transient, and we will see demonstrable evidence of that with findings on our CMR that can lead you to the path of anti-inflammatories before you consider surgery. So here's the SSFP images. Again, you'll have to take my word for it. You can actually see the pericardium here. It is thicker than normal, and you see a concomitant pericardial effusion as well. When we make our measurements on our T1 spin echo, you can see it's 5 millimeters thick. This is very specific for constrictive pericarditis. We can do some other, secondary sequences. This is that, tagging sequence that we talked about. Normally what should happen is between the myocardium and the pericardium is a small layer of fluid, right? We all have up to 50 cc's. So there's, these two structures move freely and independently of each other. When they're inflamed, the myocardium pericardium adhere to each other, and you lose that slippage or that mobility between the two. And with these tagging lines, you can actually see that, immobility of those two structures. We can also look for the hemodynamic consequences of constrictive pericarditis. Just as we had shown, one of the signs of ventricular coupling is the diastolic septal bounce. It goes by many different names. It goes by septal shudder, it goes by septal bounce, an S-shaped septum. All of those tell you the same thing, that they have this very characteristic appearance of the septum that you can appreciate on the screen. And it implies that one ventricle is filling at the expense of the other ventricle because it's surrounded by a non-compliant sac. We can also look for ventricular independence by doing real-time cine images. I apologize. We have these patients do free breathing, and we image their hearts just like you would with echo. And what we can do is we can appreciate the filling of one ventricle at the expense of the other. So in this particular case, as the patient inspires, as the diaphragm drops, you'll see that the right ventricle the septum is pushed to the left, and the right ventricle fills at the expense of the left ventricle. And this process reverses itself in expiration. So this is a sign of ventricular independence because of ventricular coupling. We can also, with real-time phase contrast imaging, look for the respiratory variations in cardiac filling, should you have this sequence. There are a lot of secondary features that we can know. We know that, at the end result of all of this, systemic and venous pressures are elevated, so you can find indirect evidence that, that the patient may have right heart failure. These includes IVC plethora and an enlarged RA, pleural effusions, hepatomegaly, and ascites. But I think the real strength, again, what I really want to tell you guys about today is the tissue characterization. We showed that the pericardium was thick. In this particular case, we can see by T2 imaging or our edema imaging, you have a bright signal where the pericardium is, indicating that there's edema there. And then sure enough, when we give the gadolinium, you can see that the LGE is also positive. So you here have both the T2 and the LG being positive. So what does that actually mean? So people have actually looked at this. They took 25 patients who had constrictive pericarditis, who went for pericardiectomy following cardiac MRI. And what they showed was when you have pericardial LGE, this correlates with histologically with a very dynamic, active inflammatory reaction with fibroblasts present, chronic inflammation, granulation tissue, and neurovascularization. So histologically, this is what this LGE uptake means. So, and not to leave PET out of this, there have been some case reports out there showing that you can actually, with FDG PET, also show evidence of inflammation in the pericardium, and that the degree of intensity of FDG uptake as measured by your SUV can predict future recurrences. I haven't talked about CT, so this particular case happened to also go for a CT. We can look at the pericardium both with contrast and without contrast. As you can see, this is without contrast, and you can see the pericardium looks very similar to as what we saw in CMR. It's thickened all around the heart, but again, it's a great tool for calcification, but bear in mind its major limitation is that there's no hemodynamic monitoring, and remember, it's really not ideal for serial imaging because of radiation. So now you have this information. Now I pose you, what do you want to do? So I hope you can see how MRI made you much more confident of the diagnosis, and it made you much more confident in what your next step would be. And I think we'd all agree that would be anti-inflammatories. This patient was treated with anti-inflammatories, and you can see now the inflammation in the heart evidenced by both T2 and LG imaging has resolved. And this is just a side-by-side comparison, pre and post. And so, and this was just a quick study that showed that patients who had reversible constrictive pericarditis, those patients had significant LGE uptake. So please remember, not all patients need to go for surgery. This is a state where you will find patients who you can reverse with medicines. Here's another case, same thing, tubular-shaped ventricles, all the things that Maan had also mentioned, the septal bounce. You do our edema imaging and LGE, and this time nothing turns up bright. What would you do in this particular case? So here I hope you understand that anti-inflammatories don't have a rule. This patient went on to get a CT scan just to show, the amount of calcium that was there, tremendous amounts of calcium circumambulating the heart. It can really be used as a great test to help the surgeon plan their surgical procedure. This is end-stage chronic constrictive pericarditis. This is only going to be benefited by surgery. And this is just showing you how CT can be used for preoperative planning and also for coronary assessment in these patients who may go to the operating room. Last case, similarly, another patient presents with right heart failure. This time you measure the pericardium, it's normal, But you turn on the LGE, the problem's not in the pericardium, it's actually in the muscle. It's in the myocardium. This is diffuse LGE uptake in the myocardium indicating amyloid. So it can be very helpful in helping you differentiate myocardial processes from, or restrictive processes from constrictive processes. So 3 slides to summarize, and then I'm done, which I think everybody will be happy. Number 1 is CMR is a very comprehensive tool. You can look at anatomy, you can look at hemodynamics, you can look at and define severity of inflammation, and this allows you then to stage and monitor your disease with therapy. So it should be used in all cases of complicated pericarditis as well as constrictive pericarditis. Point number 1. Point 2, whenever you have cases with pericarditis, you have to be looking for other things and evaluating other things. These are a spectrum of disorders. Some of these patients will present with constrictive physiology. Some of these patients will present with effusions and tamponade physiology. So it's very important that when you're looking at these studies that we're aware of these 3 different entities and that we should be evaluating our patients for all of this. The third point is we can use CMR very accurately, specifically our T2 and LGE, to stage the disease. Specifically, what I mean is, where we are in its stage of inflammation, and we can therefore help diagnose acute, subacute, and chronic states. And that becomes very important because that helps you then define your treatment and therapies. So if you have a lot of inflammation going on, these are patients who are going to benefit from your triple therapies and now all your biologics that you have present. Whereas those people who do not have inflammation, as evidenced by either T2 or LGE, this is now more chronic states. These are not patients who are going to benefit from anti-inflammatories, but rather will need diuresis and maybe surgical treatment of their diseases. So I hope you remember these 4 points, and I'll conclude there.